We have 9 presentations today. Each presenter we've asked to speak for about 3 minutes, and then we'll do a 2-minute Q&A. If you have your chat function set up on the side screen there, Tassos and I will keep track of those questions and then try to pass that on to the presenter so the presenter doesn't have to try to keep track of that. So I think, Tassos, you and I will just bounce back and forth between introducing the speaker. I'll go ahead and just go first then. The first presentation for our Lunch and Learn abstract session today from the University of Michigan, Anna Bonikowski, Proposed Vascular Surgery Pilot Program for Regional Recruitment. Anna, nice to see you. Go ahead.
All right. Well, thanks to the APDVS for the opportunity to present our work. We have no disclosures. The workforce shortage in vascular surgery has become a critical problem that is requiring an urgent need to enhance recruitment and training within our specialty. Effective mentoring of medical students is important to help enhance the pipeline. We've previously shown that early mentorship during medical school is effective, that it has a positive influence on medical students' choice to pursue vascular surgery residency, and those with vascular surgeon mentors had higher success in the match. With this in mind, we initiated a pilot program for regional recruitment targeting female medical students across Michigan and Northwest Ohio. Our goals were twofold: to enhance specialty outreach to students who may not have exposure to vascular surgery at their home institution, as well as to better understand recruitment barriers. This was a one-day program with multiple components, including didactics and panel discussions, open and endovascular simulation, as well as the opportunity for professional development. It featured 13 female vascular surgery faculty, spanning broadly across rank in geographic and practice setting. The total cost of this program was $4,030. 24 students attended the program. All students were external to Michigan Medicine, and students spanned a wide geographic range as well, from Michigan to Northwest Ohio. We then submitted a survey that focused on mentorship opportunities and barriers for entrance into vascular surgery, and our survey response rate was 75%. The participant level of training that came to this program were some undergraduates, mostly medical students, particularly M2s and M4s. And prior to participation in our program, about 67% of attendees admitted to a vascular surgery interest. Some of the perceived barriers in entering vascular surgery included lifestyle, workforce diversity, physical demands, and competitiveness within the specialty. 94% of students said that our program had a positive or very positive impact on their plan to pursue vascular surgery. A significant barrier to this is that only 50% of these students had a local vascular surgery rotation, and only 39% had a vascular surgery mentor. But 83% of attendees said that they would be interested in having a vascular surgery mentor. After the program, we've had continued interfacing with these students. Many have continued remote mentoring. They've been included on all vascular surgery emails and societal medical student program opportunities. In conclusion, this pilot program serves as an expanded outreach to enhance the vascular surgery pipeline, and it allows for longitudinal student exposure and the opportunity for remote mentoring. In the future, we plan to establish an APDVS and SVS branded regional recruitment effort to enhance early medical student exposure to vascular surgery. Our goals will be threefold: to provide exposure to medical students with an emphasis on simulation, to improve preconceived perceptions regarding vascular surgery, and to establish a pipeline for identification of excellence to facilitate active recruitment into vascular surgery. Thank you.
That's great, Anna. Given that a lot of our meetings are going to have to convert to some sort of virtual, and since you were there, sort of on the ground for this type of meeting, can you tell me some of the pluses and minuses of doing this live versus potentially virtually like this?
Live, when we had ours here, we had multiple students. They were able to sort of interact one-on-one with the multiple different faculty and residents that were there. There were a lot of side conversations that sort of were more informal. I think that was important. I mean, I had multiple conversations with medical students asking about, if I was married, if I was able to have kids and how that looked. And I don't think that in a forum that's virtual like this, that it would be those informal conversations that are very important would be feasible. I think we'd have to figure out a way to maybe establish some breakout sessions within a big sort of virtual meeting like this in order to make that more feasible, as well as the simulation component of it. The hands-on simulation was really great. We had a lot of the reps come with their endovascular equipment. I think that would be a challenge. I think it would be something that could be worked through, but we'd have to make sure, I think those components weren't lost.
Yeah, I think that's very insightful. I think a lot of the recruitment type meetings that we have, while I think the scientific part is a lot easier to deal with in terms of asking questions, I think you're spot on that the sidebar conversations that we all enjoy at these meetings becomes more challenging, particularly for somebody that we're trying to mentor or somebody that we're trying to get interested in our specialty.
Thank you, Anna. In the interest of time, we'll move to the next speaker. Matthew Smeds will provide us with a modern appraisal of current vascular surgery training education program. Matthew, can you please share your screen?
Thank you for the honor of the Zoom room. Today I'll be talking about the components of vascular surgery training programs in the United States. I don't have any financial disclosures relevant to this talk, although both authors on this presentation are trialing the V-Score program in our respective programs. Other than loose common program requirements outlined by the Accreditation Council for Graduate Medical Education, there is no universally established curriculum that is followed by all sites. The APDVS has established both the clinical and basic science curriculum that is available for all members to use, but educational components are largely dictated by individual programs and vary from site to site dependent on the program director, trainees, resources, and goals of the specific programs. The curriculum committee of the APDVS has been tasked with determining the feasibility of creating a common core curriculum in vascular surgery using the V-Score system. The goal of our study was to appraise the current status of vascular educational programs in the United States vascular surgery residency and fellowship training programs, and to perform a needs basis analysis for a universal curriculum. Program directors at 112 U.S. vascular training sites were sent a request to fill out an anonymous electronic survey via the Research Electronic Data Capture System. The survey asked questions pertaining to program characteristics, educational components of their programs, and who was responsible for developing it, as well as their thoughts on needs for a universal curriculum in vascular surgery. The overall response rate was 71%. 53% had both an integrated vascular surgery residency and fellowship, with the remaining being solely fellowship in 39% of the cases, or an integrated residency alone in 9%. Nearly all had at least one regularly occurring weekly vascular conference, and 74% had more than one. On average, programs spent 2.6 hours per week in formal vascular conferences, and there was no difference between these programs with a residency and those that were fellowship only. Just as a point of curiosity, Wednesday was the most common day that people had their meetings. There are a variety of components used by vascular surgery programs across the country. The most common elements used on a weekly basis in the vascular surgery conference are review of upcoming or completed surgical cases and lectures on vascular disease processes. The most common components performed overall at variable frequencies were morbidity and mortality conferences, journal club, and review of vascular labs, and lectures on disease processes. In about half of the programs, the program director was responsible for creating the schedule and curriculum for the weekly vascular conference. The associate program director had this role in 20% of the programs, while trainees had this role in 20% of the programs as well. When looking at who presented the material, however, trainees were responsible in 78% of the programs. Most programs created their schedules on a weekly basis, although a quarter planned their entire schedule a year in advance. 17% of respondents used a standardized curriculum in vascular surgery, such as the SAVES curriculum, and about half used a textbook, most commonly Rutherford's, to create their standardized schedule. When asked how much time trainees should devote to studying vascular surgery-specific topics independently, 62% thought trainees should study 4 or more hours per week. When asked how much they think trainees actually spend, 55% believe they spend 2 hours or less per week. Most respondents agree there is a need for standardized curriculum in vascular surgery, and if it was created, it should be approved by the Vascular Surgery Board, and most would use it if it was available. However, only about half of the programs would be willing to pay for the product. In conclusion, there is a significant variation in vascular surgery education program components and a significant dependence on trainees to create and present the material. Most program directors in vascular surgery support the creation of a standardized vascular curriculum and would use it if created, although there is not much support to pay for this product currently. I'd be happy to take any questions.
I don't see any questions in the queue, Matt, but I would like to ask you, what do you think is the best way for application of a curriculum that is developed by vascular surgeons for vascular surgeons, as a type of a weekly conference go-to material, as a supplement to the morbidity and mortality conferences or to the case presentation conferences? How do you envision that?
Well, I think any curriculum that's put forth needs to be pretty versatile in the sense that it needs to be able to be used however the individual programs want to use it. I think there's a lot of concern from programs who have a pretty well-established curriculum already that they don't really want to mess with a good thing. They've already created a good curriculum. So anything that is created needs to be able to be incorporated into existing curriculums. I think that's probably the most important thing, and that's probably the most tricky thing as well.
And what about renewal of material, ongoing renewal of material?
So that's a good question. You know, currently the V-score, which is what we're trialing right now for this universal curriculum, is modifiable even up to real time. And we've been modifying V-score modules almost real time within a month or so of the modules coming out. So as long as you have authors who stay on top of things, you can change things almost in real time using the V-score system.
Okay, thanks, Matt, for that great presentation. Next up is Bridget Smith. Predictive probability of the value of ACGME vascular surgery milestones. Bridget, nice to see you.
Great, thanks, Dr. Lee, for the introduction, and thank you so much for the opportunity to present our work today. I have no disclosures. There we go. So we're all familiar with the ACGME vascular surgery milestones, which include 6 competencies and 31 sub-competencies. Each sub-competency includes a developmental progression of milestones from level 1 through level 5. The competency target for graduation is level 4. This is an indicator of a trainee's readiness for unsupervised practice. So what we really want to know is if we assess a trainee at any given level, at any given point in time during their training, how likely are they to achieve the competency target for graduation of level 4? So the objective for this study was to determine whether vascular surgery trainees' milestones achievements throughout training are predictive of their ultimate achievement of competency targets at the time of graduation. The predictive probability value is the estimated probability that a trainee will not achieve the recommended graduation target of level 4. A logistic regression approach was utilized to calculate PPVs using prior milestone ratings as thresholds. The generalized estimating equation model was applied to each of the 31 subcompetencies separately, utilizing the national ACGME milestones data for 122 vascular surgery fellows who graduated in 2018. We found that all 31 subcompetencies demonstrated PPVs at all time points of assessment and at most thresholds of assessment. This is an example PPV matrix for the subcompetency Patient Care 6 Technical Skills Open Surgical Skills. This matrix was generated for each of the 31 subcompetencies. On the left, you see the milestone assessment rating levels, and from left to right, there are 3 time points of reporting during the fellowship program. T1 is 6 months into the program, T2 is after 1 year, and T3 is with 6 months remaining in training. The values in the cells represent the probability that a trainee will not achieve level 4 by the 4th and final time point of reporting. For example, if I assess my fellow at level 2 after 1 year in the program, there's a 48% chance that they will not achieve level 4 by the time they graduate. This table provides the range of PPVs for each of the 6 core competencies across the 3 time points of reporting. The least predictive subcompetencies were in medical knowledge, while the most predictive subcompetencies were in systems-based practice and practice-based learning and improvement. Several key trends emerged. First, as the time of assessment approaches the time of graduation, the PPVs increased. This figure shows the average PPV for each competency domain along the y-axis and at each time point of assessment throughout fellowship on the x-axis. Milestone ratings are more predictive of the risk of non-achievement of graduation targets, the closer one is to graduation. This figure shows the average PPVs for each competency domain on the y-axis at each time point of reporting throughout fellowship. So you can see the same trend in the matrix for patient care 6. In addition, as you look at the matrix for patient care 6, you'll see another trend. As the prior milestone ratings are lower, they are more predictive of failure to achieve level 4 at graduation. This figure is also for PC6 subcompetency. As prior milestone ratings are higher, the PPVs decrease. And this was also true for all of the other 31 subcompetencies. So in conclusion, achievement on the milestones during training is predictive of final achievement of competency targets at the time of graduation. Ratings are predictive from the very first time that you assess your trainee. Lower scores are more predictive and later scores are more predictive. So program directors can use this data to identify struggling trainees and intervene with individualized learning plans prior to graduation. Thank you.
Great. That's a wonderful summary, and I hope you're on Milestones 2.0 committee based on all that research looking at it. What do you think if you're not on the committee, and there's people on the call that are on the panel that are on the committee? What's one tangible thing from this volume of sort of analysis that you want to tell to fine tune Milestones 2.0?
I think one of the most interesting things was the discrepancy in the predictive probabilities between the patient care and medical knowledge sets and the others, the non-technical, sort of non-cognitive professionalism communication areas. And that could mean one of two things. Either we're using the tool appropriately and there's wide variability in performance in those areas, or we need to improve the tool so that we have a better ability to understand what systems-based practice is, what that means, so that we can more accurately assess our trainees in that area. So I think there's some discussion to be had about what the takeaway point is on that area, but I think that will be an interesting point of discussion. And I am on Milestones 2.0, so I will be weighing in.
Good. And then how about comparing PGY 4s and 5s and the O and 5 versus the fellowship? I think that'll be interesting to get past this idea that they're different types of people, but that they're actually in their senior years of vascular training.
I'm glad you asked. I have one slide that I didn't show. Well, this one doesn't show the O5s. I will tell you that we ran the same analyses with the 5-year program for the integrated residency. There were far fewer learners at about 55 that we were able to run this on. So the values are just not as strong because the numbers are just not as high. But over time, as we can combine cohorts, we may be able to show some stronger predictive values. But the numbers we were seeing were similar.
Thank you, Brigitte. Todd Vogel and John Taffel now will discuss the effects of vascular surgery training paradigm on crisis simulation performance.
Great, thank you. First, I'd like to just thank the selection committee for the opportunity to present this project to everyone, and I'd also like to thank everyone that collaborated on this. So to begin with, we have no disclosures to make. The objectives of this project were to evaluate the performance of vascular surgery trainees on surgical crisis simulation. So this involved comparing 05 residents versus 52 fellows. The two simulations involved were an open elective carotid endarterectomy, and the crisis portion of that involved the patient awaking with signs of stroke. The second simulation was an endovascular aneurysm repair for a ruptured AAA. And the crisis portion of that simulation involved in the occlusion balloon deflating during the procedure and an endo leak that occurred. So in terms of methods, senior level trainees were evaluated by a practicing vascular surgeon, and this occurred at the Midwestern Vascular Surgical Society meetings during the years of 2018 and 2019. Scores were assigned for each step of the procedure and for quality of the final product. Scores for the procedure would range from 1 to 5 in terms of possible scores, and those were based on a detailed rubric that was provided to each evaluator. Afterwards, we tallied up these scores and divided them into 4 key competency categories. Those categories are as follows: situation recognition and decision making, which included things like recognizing the patient awaking with signs of stroke and making the decision to reoperate. Procedural flow included knowing the steps of the procedure, being able to state them, and following them accurately. Technical skills included things like performance of the revision closure in the CEA and placement and deployment of the main body in the EVAR. And then interpretation and use of imaging included interpretation of things like a CT angiogram or Doppler imaging and decisions based off of that imaging. So on to the results. These are the overall scores for both simulations. As you can see for the CEA simulation, there was no significant difference between the two groups. And here we have the 0-5 residents are in the black bars, and the fellows, the 5-2 fellows, are in gold. However, for the EVAR simulation, there was a significant difference, with the 0-5 residents significantly outperforming the 5-2 fellows. When we looked at the CEA broken up into those key competency categories, we also found there was no significant difference between any of those categories. However, when we looked at the EVAR, which was significantly different overall, there were also significant differences in two of those categories, and that was procedural flow and interpretation and use of imaging, with the residents again outperforming the fellows. So in conclusion, 0-5 residents and 5-2 fellows demonstrated equal performance on a CEA crisis simulation. However, on an EVAR for ruptured AAA crisis simulation, 0-5 residents demonstrated superior performance compared to 5-2 fellows. And those significantly different categories, again, were procedural flow and interpretation and use of imaging. So reasons why 0-5 vascular surgery residents perform better in an endovascular crisis simulation are unclear. And further investigation using simulation to compare these two groups would be very useful in the future. So that concludes this presentation. Let me know if we have any questions.
Thank you, John. I have a question for you. Do you have what was, first of all, the number of people that were tested in each category, and what level of training these people were in the two groups?
Sure. So I have a quick slide here on some of the data. So we had 27 fellows and 13 residents that were tested. And what was the other question regarding?
What level of training they were at?
Right. So they were all in their final year of training. So 5th year for integrated residents and 2nd year for fellows.
I don't see any other questions on the grid. Yes. So next is Alikan Lalani, who will discuss the evolution of the integrated vascular surgery curriculum. Alikan, go ahead and share your screen.
Good afternoon. Thank you for the opportunity to present. I have no disclosures. The total time in an integrated vascular surgery residency is 60 months. 18 months out of that is required for core surgery, 30 months required for vascular surgery rotations, and 12 months are at the discretion of the program director. Few of these months can also be used for research. The objective of our study was to quantify and classify training curricula of integrated vascular surgery training programs. We also wanted to provide a summary for program directors to establish or revamp their curriculum. We obtained rotation schedules from 51 of the 54 existing programs at the time of this study. The rotations were then classified into vascular surgery, core surgery, or non-operative rotations. The most common non-operative rotations included vascular lab, interventional radiology, and cardiology. The average time that was spent on rotations during training was 34.1 months on vascular surgery out of the 42 total permitted months. 18 months were spent on core surgery and 7.9 months on non-operative rotations. Of note here through this diagram, in the PGY 1 and 2 years, only about 1/3 of the training time was spent on vascular surgery. This increased to about 50% in the 3rd year. This diagram here depicts that out of the 70% total time allotted to vascular surgery, only 59% of the time was spent on vascular surgery rotations. The other 29% was on core surgery, and 12% was spent on non-operative rotations. We also developed a survey for the program directors that submitted their rotation schedules. A 72.5% response rate was obtained from these surveys. We asked all program directors what was a rotation that they started with at the beginning of their residency and that has now been taken out of their curriculum. The most frequently removed rotation was cardiology. The most important non-operative rotation that program directors reported was ICU and vascular lab. The most important core surgical rotation that was reported by program directors was trauma surgery. We also asked program directors what were the common barriers that they faced to expansion of their vascular program. The number one listed barrier was lack of funding. About half the program directors also reported lack of support from their general surgery department, and there was also some lack of volume that was reported as a barrier to expansion. In conclusion, residents are spending a significant amount of time on non-operative and non-vascular rotations, especially early on in training. There's less time being spent on vascular surgery than the permitted 42 months. With decreased open surgical numbers, reevaluation of the current curriculum is warranted to help maximize the amount of months spent on vascular surgery. Thank you.
Any questions for Alikan? I have a question for you. There are programs that have integrated research into their curriculum, and they have a longer training period. How did you account for those?
So if you had a research year built into your curriculum, for example, Stanford has 2 years of research or Mass Gen has 2 years of research, that was not included as part of the 60 months. These are only strictly for the 60 months that were not separately researched.
Okay, thanks, Alikan. Appreciate that. Next one, NJ, are you ready? Vascular Surgery sponsored comprehensive summer internship program for undergrad and medical students.
So my name is NJ Jung from OHSU, and I want to thank everybody for the opportunity to share our experience with 10 years worth of summer research program here at OHSU. I have no disclosures. So much is written about and discussed about the importance of attracting young, talented people to surgical specialties. And we also know that students are influenced by early positive experiences when making career decisions. So there is a mutually beneficial relationship that can be formed between institutions and students through the form of research experience. So in the spring, the research staff here, along with faculty, will try to identify 3 projects that are doable in a 8-week period, which tends to be retrospective chart reviews. Faculty mentors are identified and assigned to the project. We submit an IRB and get approval prior to the start of summer. And once the research students arrive, they're assigned to a research project, usually 1 to 2 per project. They meet with their PIs weekly and they present updates bi-weekly. In terms of the formal program, they actually meet with the departmental statistician with introduction to biostats. They get an introduction to clinical trials. They sit on IRB panels. Obviously, they participate in all of the departmental and divisional conferences. And then they're assigned specific days where they shadow operating room, clinic, and ward rounds and meet with their division chief once or twice during the summer period to kind of talk about what life as a vascular surgeon is like. The call for the application is put out through both the OHSU website as well as the SVS website. And we do advertise broadly at local colleges' career centers. Students submit a CV and a cover letter, and we do give strong consideration to those that have no background in research or have poor opportunities for research experience. And we also look at wording in the cover letter to look for those and their motivations. Students that are selected have a phone or in-person interview depending on where they're located and then are chosen from that pool. When they arrive, they get an extensive orientation by our research staff, and they're also given a research guide that goes over things like expectations and etiquette, like dress code, which seems obvious. They're given a crash course in vascular terminology and an EPIC tutorial. The costs of the program include costs for the onboarding. They do get a modest stipend, so undergraduates get $500, medical students get $1,000, and then the amount of time that it takes to put together this program in the spring and summertime amount to about 0.1 FTE of our senior research associate's time. Students that have presentations that are selected at conferences will have their travel costs covered by our division. So on average, it comes out to be about $1,500 per student. The funding for this program is through voluntary contribution of honorariums, industry, or legal consultations by the faculty. So no clinical revenue is used, and we don't use any government or industry research grants for this program. So in the past 10 summers, we've had 47 applicants. Prior to 2014, most of those students were OHSU medical students between their first and second year. We underwent a curriculum update in 2015, and so they no longer had summers off between their first and second year, and that's when we saw a shift to undergraduate students and then medical students from other institutions. Of those, 20 projects were presented at local, regional, or national meetings by the participating students. That number is closer to 50 when we account for projects that started out as summer internship projects that were later finished by residents or fellows, and 25 peer-reviewed publications with 26 of those students listed as contributing authors. Again, these are only summer internship students. We do, on average, get 2 to 4 students that are interested in surgery or vascular surgery that do research with us throughout the school year that we did not count in this work product. In terms of the medical students, 23% are now in surgical training or practice. Of the 29 non-medical students, 34% of them are in medical school, and 3 out of those 10 are either in surgical residency or have identified as applying to surgical residency. 14% are in other health fields like RN, PA, or nurse practitioner. 21% are still in the research field, mostly working as study coordinators, and a majority of them in academic or private sectors. 14% are currently applying to medical schools. So in conclusion, a defined summer research internship does result in publishable manuscripts. It encourages the exploration and pursuit of healthcare careers, and it is affordable without utilizing clinical revenue or grants. I'll take any questions.
No questions on the chat box. Have you done a long-term thing to see the folks and kind of where they are now, or do you intend on that, like down the road, to see if they all become surgery folks?
Yeah, so these were the numbers that we had of the people. Very few are lost to follow, I think. Of the medical students that were in the program, 3 of them are in the surgical residencies, 3 in emergency medicine, 3 in OB-GYN, and then various students. Again, I think the medical students oftentimes that are interested in vascular surgery will sort of contact us outside of this summer period. And so at least through this program, I think we are seeing more generalized interest in medical field. And so the more recent students will have to track a little bit further to see where they end up.
Okay, great.
Very good.
Faisal, we're going to try again, buddy?
Yeah.
All right, let's do it.
Anyhow, good afternoon, everybody. Thank you so much for the invitation to speak. This is a survey which is done in our med school, and all the credit goes to Marvin Chow, who is a medical student who led this course. I have no pertinent conflicts of interest to report. So the first question is, why did we do this survey? And the reason is, at national level, we see that there is an anticipated shortage of vascular surgeons. We see that there are competing specialties such as interventional radiology and CT surgery, and there's a perception that they may be gaining more attractive students or more competitive students than vascular surgery is. A brief introduction to our program. Our vascular surgery integrated program was started by no other than Dr. Amy Reed in 2010. We matched our first candidate in 2011, and we have matched every single year since then. We have a 100% board pass rate, and back 80 years ago, we did realize that in order to attract our own students in our own med school, we need to start an interest group. So we started our vascular surgery interest group in 2012. We have our own student body with elections every year, and there are multiple sessions which are done throughout the year to expose them to vascular surgery. So we're very fortunate that majority of our med students are actually exposed to vascular surgery in some shape or form throughout the 4 years of their training. So we sent a brief survey of 23 questions. The first set of questions will essentially address the demographic questions. Then we very specifically asked the next set of questions to address why did the students choose the medical career to begin with. And then the next subset was those questions was pertaining to those students who were interested in some surgical career, but were not sure exactly what. And then the last set of questions was focused on those people, those students who were interested in vascular surgery alone. So our response rate was 26%. 59% were females, and 2/3 of the respondents were varied from age range 21 to 25, all Gen X people. And when we look at the level of their education, majority of the survey respondents were third-year medical students, 38%. Other classes were sort of half-half, equally divided. So of all the students who surveyed, 63% expressed some interest in some shape or form of surgical careers, which is unusual, and perhaps it's a selection bias of only those students who were interested in surgery filled out the survey. When we look at the three most important factors which were identified in the cohort of students who were interested in surgery, were number one was level of education, which was basically third year of med school. Number two was surgical mentor, and number three was wanting exposure to vascular surgery. We were kind of surprised by this, but that's what the data is. Then we focus on those students who were interested in vascular surgery. And the statistically significant reasons for interest in vascular surgery were a variety of cases, multiple anatomic areas to operate on, and ability to finish training within 5 years seemed to be the most attractive reasons for interest in vascular surgery. Now, if you look at the subgroup of students who were interested in surgery and then interested in vascular surgery, the three most important things, as I mentioned before, were ability to do a variety of cases, multiple anatomic areas of the body, and subspecialized training within 5 years were the most attractive features. We were also interested in knowing as to why were people not interested in vascular surgery. More specifically, those students who were interested in surgery overall, but not interested in vascular surgery. So the most common reasons cited were patient population, and the details of the survey were basically, it boils down to the fact that vascular surgery patients, as we all know, are complicated surgical patients. So that was a distractor for students. Students' marital status, students who were married were not attractive to vascular surgery. And at the same time, students mentioned that a long duration of training was not an attractive feature for them for vascular surgery. When we asked them about the overall concerns about surgical career, 60% of them cited burnout as a major concern. The other factors cited were stress, work hour, lifestyle, and others. And when we look at others, there were a few comments which were said by students which we thought were pertinent to mention. For example, one student mentioned that he never shadowed a surgeon who was happy with his or her career. That tells you that at the end of a long day or during a long operation, even one unthoughtful remark can leave a lasting impression on young minds. The other features which were not attractive to them were surgical culture, not enjoyable, the concept of hierarchy in surgery. So for the sake of time, I'll stop here to summarize the factors which were associated with choice of any surgical career were third-year medical students and surgical mentorship overall, and wanting exposure to vascular surgery. I know Jason Lee's group has shown that before as well, that exposure to vascular surgery alone can be an attractive feature, not only to vascular surgery, but to any surgical career. Specific factors associated with choice of vascular surgery included variety of cases, multiple anatomic areas of the body to operate on, and the duration of training. But factors which were associated with not choosing vascular surgery career were also duration of training, patient population, and marital status. And let's not forget that the most common concern among the students for choosing a surgical career remains burnout. Thank you so much for the opportunity. I'm really sorry for the delay.
Great job, Faisal. I think that it's good, that it's heartwarming to know even 10 to 12 years later, similar surveys of students, it's the same reason. So even based on this morning's generational talk, I think core to our principles of why people choose our specialty is staying consistent. Go ahead, Tassos. Why don't you introduce the next one?
Yep. Mark Matos is going to be our next speaker. That's longitudinal assessment of all the operative skills of senior independent vascular surgery fellows and integrated vascular surgery residents, a 4-year comparison using a simulation testing program. Mark, can you please share your screen?
Thanks, Tess. Thanks, Jason. Good afternoon, everybody. My talk today looks at trying to compare the operative skills of PGY-7 fellows versus PGY-5 residents over a 4-year period based on our advanced surgical skills simulation testing. Dr. Brown and I have nothing to disclose. There's been national concerns about whether or not the training paradigms for both of these programs are graduating trainees with equal or similar operative experiences. And based on that, we used our meeting to determine, based on its content, whether or not there is a difference between the PGY-5 senior residents and the PGY-7 senior fellows. If you don't know our program, it's a 2-day program. It assesses proficiency and independence. It looks at PGY-7 and PGY-5 senior trainees, faculty or program directors, division chairs, and are all board certified. We use high fidelity simulation. We have a total of 12 hours of OR time, 30 to 60-minute procedure constraints. And the key here is that fellows and residents operate in silence. Faculty serve as passive first assistants silently and are silent proctors. Our motto is test first, teach second. At the end, we provide summative feedback at the completion of each procedure, and then we provide individual summative and comparative assessments within 2 months. These are the index procedures we tested them on. This is the study content: 69 PGY-7s, 29 PGY-5s, 55 different faculty, 136 total over the 4 years. Residents and fellows performed 10 to 16 simulated procedures. There's 3 unique procedure-specific assessments. Over this time period, we did 1,125 simulated procedures, 3,000 individual assessments, and 35,000 data points were generated. We compared performance using the t-test. This is the assessment metrics we use in the proficiency definitions. Global rating scale, which is a Likert scale-based scoring system. You had to have greater than 80% to be looked at as proficient. An overall performance summary score, which is a level 4 or 5 based on the PC6, PC7 milestones, and then the critical task performance, which it looks at volume and time efficiency and procedural steps. You had to have 100% completion in order to be deemed proficient. The results show that overall, when you look at all 4 years, there's really no difference between the PGY-5s and PGY-7s for global rating scale, overall performance, and the critical task performance, and you can see the numbers there. When we looked at it over a 4-year period longitudinally, again, there was no difference. You can see that in 2016, that basically there was a much better result with the PGY-5s than the PGY-7s, but it didn't reach statistical significance because the numbers were so low in comparison. When we looked at open versus endovascular, because there's concerns about the skill set for each of the different paradigms, one versus the other, there was no difference in the open vascular skill set between 5s and 7s, and there was no difference in the endovascular skill sets, either combined or by individual metric. When we looked at intergroup comparisons to see whether or not the 5s were better from an endovascular approach versus an open, in the 7s versus endovascular versus open, you can see that for the PGY-5s, the overall proficiency score or overall performance score was slightly better and came out to a 0.05. But the global rating scale, which is a more comprehensive skill task metrics, did not really bear that out. For the PGY-7s, they were better in both the global rating scale and the overall performance score compared to their endovascular work. But you can see from the critical performance metrics for both the PGY-5s and 7s, both of them were fairly poor, with none of them greater than 50% achievement of a proficiency level, and none of them were significant from an intergroup point of view. When we looked at individual procedures, this is a busy slide. It'll be better when you go and look at the slides in depth rather than a 3-minute presentation. There was no significance between any of the 7 open vascular procedures between PGY-5 versus PGY-7 in any of the metrics that we looked at, with the p-values ranging from 0.14 to 1. When we looked at the endovascular procedures, the only thing that was significant was an OPSS from the renal artery stenting, of which there were a few numbers, and from the overall combined for contralateral iliac artery balloon and stenting. Otherwise, the p-values were not significant between the 2 groups, indicating that their operative capabilities were not significantly different. The thing that was interesting that Bill and I found is that there was a high degree of operative failure rates based on the definitions we created. If you look at the open vascular, overall, the failure rate range 23 to 44%, PGY7 is 22 to 24. And if you go down the list, you can see that there is a high number of failure rates for both the GRS, OPSS, and the critical performance metrics for both groups in both types of procedures. When we look at 7 index procedures, you can see that to perform an open AAA, nearly 30% of all our trainees couldn't perform it at a proficient level. For TVARs, a high number, 26 to 34%. And so you can see that the range of failure is quite high for both groups, and both are similar in their failure rates. In summary, this is the first longitudinal objective comparative assessment of the operative skills of PGY7 fellows and PGY5 residents. Both the residents and fellows display similar operative abilities. However, both groups displayed similar, surprisingly high failure rates in their technical skills and procedural knowledge, and this was consistent over all 4 years of the assessment. In conclusion, though, we do think the national concerns over inequality of operative skills in our vascular trainees is really unfounded, and that the 05 and 52 training paradigms are producing trainees with similar operative competencies, but higher than expected failure rates. I think our efforts should not worry about whether or not one's producing a better trainee than the other, but we should focus on training and assessment metrics which seek to improve the procedural knowledge and operative skills of all the vascular trainees to bring the high failure rates down to less than 10%. Thank you for letting me present this data.
Mark, great presentation and great data as usual. I will give you my personal bias because I have hired in the past few years graduates of both programs, and I will agree with what your study has shown. We don't see any significant difference in the ability of these graduates to operate independently at the end of their training. Now, there is a question by Isam Kolilat that asks if you did, if the evaluators were blinded in your study.
The answer is yes. None of the evaluators had anything to do with the data. Dr. Brown and I don't personally perform the assessments. We do all the data collection, so we stay at arm's length. What we do, though, is provide all the program directors and chairs who had fellows and residents participate. We give them a pretty in-depth assessment, 24-page individual assessment, a 7-page summative assessment, and then a 5-page comparative assessment against all the other trainees in the meeting, so that they get an idea about where their performance curve lies compared to other people in the same level of skill.
Thank you. I'll pass it on to Jason now.
Okay, thanks. Final abstract, envious position to be in this right before lunch. Crystal Maloney, attitudes regarding pregnancy amongst vascular surgery trainees and program directors, a survey of all of us. Crystal, go ahead and share your screen.
All right. Good afternoon. My name is Crystal Maloney. I'm coming from Pennsylvania Hospital, and I was going to start with a short story. So way back when I was interviewing for general surgery residency, I was at Brown University, and one of my interviewers stopped in the middle of the interview, and she said, "You know, this is a really great place for women to train." And this struck me. I'll never forget it. It wasn't something I was looking for. It wasn't something that I knew that I wanted, but I could tell when I looked around that this was true, and it was something that benefited everyone in the program. So that was where I matched. That was where I trained. What I saw over my 5 years there, that this resulted in incredible recruiting power as well as retention. So 2 years later, I am searching for a vascular fellowship. That's what I'm looking for. I found that support system in the section of vascular surgery at Pennsylvania Hospital with Dr. Calagaro, who was incredibly supportive as I started my family, and it offered wonderful work-life balance. So this is something that everyone is interested in. It's a constant challenge. These are 2 articles that were published recently in the past year in the New York Times and The Economist, and people are writing about it because it's important to them. So what about the medical student that dips their toes into vascular surgery and says, I really like it, but I want a family, so it's not for me. Or the trainees or attendings that struggle with this. I think understanding this better presents an incredible opportunity to improve the quality of life as we practice, but also improve our recruiting power. So this is a project that I did with Dr. Caligaro in the section of vascular surgery at Pennsylvania Hospital in conjunction with Amy Reed. And we wanted to look at people's opinions of pregnancy and starting a family through training. So we sent out a survey to residents, fellows, and program directors. It was 20 questions. It was sent to 600 trainees and 173 program directors. We had a similar response rate among every group. The majority of respondents were male and less than 40 years old. So what did we find? All of these results are statistically significant. The trainees and program directors in every group reported that their workload significantly increased when a peer or trainee was pregnant. Males more than females believed that a pregnant female was less capable of performing her job. Women significantly more than men did all of the following. They delayed having children, 80% versus 44%. They were worried about how pregnancy would impair their professional advancement. They were concerned for how they'd manage their time once they were pregnant and had started their family. They didn't want to burden others by starting a family. They were concerned about how they'd manage their stress. They were encouraged not to start families. And they were worried about the opinions of others if they would become pregnant and start a family. More females than males regret their career choice in vascular surgery as it relates to starting a family. Program directors more than trainees cited an unsupportive home environment as a major barrier to starting a family. And trainees more than program directors cited safety concerns as a major barrier. And this was mostly pertaining to radiation safety. Females more than males cited a lack of mentors as a major barrier. So overall, there's obvious incredible discrepancies across the board and really opportunities to bridge these biases and knowledge gaps. And I think digging into this deeper is an opportunity to grow as a field and improve the quality of life for all of us that are already in the field and to recruit more people into it. And that's all. I'll take questions.
Great, wonderful presentation. I think a lot of very pertinent topics that I think often we all perhaps hide behind a little bit, and I think need to be on the forefront of discussion. Do you feel that, I think there was an initial wave, if you will, of interest in certainly the 0 and 5 applicant pool of females. It was a little bit of chatter this past cycle, if you will. The numbers either have plateaued or even might be coming down. I'd be curious what some of the other panelists think, but Crystal, wonder what your thoughts are about that, if you've noticed that just in your discussions or going to meetings and talking to other vascular surgery applicants.
I think the 0 to 5 program represents a great opportunity because it does cut off time from training. That being said, it's harder to build in those research years that people often target to start a family. But if you look at the numbers of respondents and people that took the survey, there are a lot of female residents as compared to fellows and even attendings. They're a large cohort of the younger part of the field.
Great. Tassos, any other last minute comments? Otherwise, I think we'll wrap up this excellent research portion of the meeting today.
No, I will agree with you. We had great presentations throughout this lunch session, and I will hope, that next year we can keep that. That's my suggestion to Mary at least. And we'll see everyone in the business meeting.
Great. Okay, guys, thanks.